I'm going to introduce Dan Palazuelos, who has brought our guest in today, and he can give an introduction, and then we can start going.
Great, thanks, guys. It's great to see such a strong showing. We wanted to have this Tuesday update because a lot of folks have heard about this Financing Alliance for Health. And a long time ago when I sat down with Gary and said, there's this Financing Alliance for Health, he said, I'm not sure I understand what they do. And I haven't given a really good answer to you yet, Gary, to some extent, because we haven't really had somebody heading it. We went through a very long process trying to find a candidate to be the CEO, and I participated in that, and it took actually over a year. And you know when you're looking at many different candidates and then suddenly one arrives and it's like the other ones never even existed? So Angela Gichaga is that candidate. She's now our new leader in the Financing Alliance for Health. Partners in Health is one of the founding organizations and partners. I participate on the technical advisory group. And just a word about Angela, and she'll tell you a little bit more about herself. Angela's from Kenya, and she brings to this job an incredible wealth of experience and information. She's trained as a physician, has worked in a busy public sector job, also has worked in management with the Ministry of Health, has also worked with NGOs, some that she's launched herself, and has also worked in the consulting world. So she's kind of seen all the different pieces, and now she's decided to become face, heart, and soul of the Financing Alliance for Health. And so it's my great pleasure to introduce her, to have her come up here and tell you a little bit more, and to finally answer the question, what is the Financing Alliance for Health, and what is it that they do?
Thanks, Dan. Good morning, everybody. Fantastic. I trust everyone had a lovely, lovely evening yesterday and is happy and excited for today morning. I'm really happy and excited to be here. Thank you so much, Gary, for extending the welcome. Thank you so much, Dan, not only for organizing this, but for all the great work you do with us. I'm so grateful. As you've had, my name is Angela, and I'm very grateful to have this opportunity to talk to the team here about the Financing Alliance for Health and the great work that Dan and the team have been doing thus far. I just recently joined. It's a month now, a month ago, and I've been doing. Getting up to speed with the team that has been on ground and hoping to push this forward. I have a short presentation here, but I want this to be an interactive session. So if there's at any point you want to stop me to ask any questions, clarifications, I do have a section for questions and clarification at the end, but please feel free if something is burning and you would like to raise it. Okay? Are we good? Yes? Fantastic. Financing Alliance for Health. So why the Financing Alliance for Health? Community health is important. Different sections of the health sector agree to this to different extents, but it has been more of a qualitative perception among the team, and people have different perceptions. So what we're trying to do is say, look, everyone wants to reach universal health coverage. Even the new WHO Director General is saying, my priority is universal health coverage. So how do we actually achieve this? How do we actually achieve reaching the whole population and ensuring that everybody has access to basic healthcare? One of the accelerating factors in the past couple of years has been the threat of a pandemic. The Ebola outbreak in West Africa, helped people realize the community health volunteers who are there, who helped in identifying cases, who helped in referral of cases to the treatment centers, who helped in follow-up and educating the public, was seen to be very important. So then we got a data point there. This team of people, yes, who had been trained in some basic healthcare, were able to contribute to the overall control of the pandemic. in July 2015, Ray Chambers, the UN Special Envoy, gathered a group of people and said, okay, now we need to start putting data and numbers behind this qualitative perception of the value of community health workers. And so a report was written in terms of trying to identify what is the return on investment of investing in community health workers. And so high economic returns were identified, and I'm going to go that into details, but saying community health workers have been seen as effective and a great addition to the overall health system in terms of the service delivery, in terms of the fact that they help prevent illnesses and you know, in the promotive aspects of healthcare, and ensuring that these people who are kept healthy are able to continue engaging in economic activity and contribute to the overall GDP. So why was this important? Funding is suboptimal. Current funding is suboptimal. And what does that mean? Different pockets of organizations have different pockets of money, and everyone is doing specific things in specific areas. And so we're not able to actually leverage the entire optimal ability of the funds and resources that are available. We need more funding. We need to get more from the current funding we have, but actually we need to crowd in new sources of funding. And what does that mean for us? As the Financing Alliance for Health, we believe that we need to look towards increasing the domestic funding, and so looking locally to the government and the local people in country, as well as crowding in new sources of funding. People in the private sector who now respond to, you know, the quantitative aspects that we're bringing to the table, who now respond to the ROIs, who now respond to saying, okay, so you're saying if we invest in these other additional aspects of healthcare, we're able to contribute more to the GDP. We need to be able to crowd in these people in the private sector, as well as thinking about innovative ways of financing. Most countries that we have worked with and are in conversations with have reached the point of saying community health work is important. The community health system is a very key aspect of the primary healthcare delivery system in the larger health system strengthening space. However, this is what we have. We have a limited fiscal space. We barely can afford the current team that we have. How do we actually start investing in community health worker systems? And we are saying we have different options, different financing options that we are currently developing with some of our partner organizations to think about how do we have countries being prepared to access different kinds of bonds, thinking around health for debt swaps, thinking around how do we actually ensure that we are moving towards performance-based financing. So you show results and you're able to trigger more funds to show results, and that keeps accountability on both ends. For the countries, they know that they need to invest and invest wisely and also think about showing results, as well as the funders are now convinced that there is value in investing and are able to crowd in more people. This is something we've been discussing, and this is what I've spent quite a bit of time in New York the past week doing. It's not enough to have different people, especially in the Ministry of Health, saying community health systems are important. You know, people in our implementing partner space saying this is important. We need strong political leadership. We need buy-in from the top. We've been working with Sierra Leone and Liberia, and I'll go into this in more detail. But in Liberia, one of the success factors was, first of all, Her Excellency President Salif, who is a member of our high-level council, basically said, this is something that is important, and this is something that we're going to do as a country. Yes, we have challenges in terms of the fiscal space, but we're going to try and make this work. And we cannot underestimate and undervalue the contribution of actually having strong leadership and buying and ownership in country for these kind of systems. This ensures that, you know, beyond political terms, beyond specific timings within the cycle of the country, there is continued buying, ownership, and leadership by the local public sector to implement and ensure that this is a success. So, and that's why I thought it was very important for us to highlight that here. I alluded to this report, and it's available on our website, and I can provide it a soft copy to Dan to disseminate to the team for those who would be interested. And this is the return on investment report. What it basically showed was, if you put $1 towards community health workers within a well-supported system, key, within a well-supported system, then you are able to get a $10 return in terms of productivity. What does productivity actually mean? The people who have been given the health education in the community, the people who have been encouraged to go for immunizations and given the family planning commodities that they require at the community level, are able to now economically engage in their different industries and contribute to the GDP. Insurance. This cannot be emphasized, and we learned a lot about this, and we got great evidence around this, especially in the work that we're doing in the pandemic control for Ebola. Employment. If you look at the large community health worker programs, especially in Africa, most of the programs are employing young people, and so community health workers is around trying to address the issues around high youth unemployment on continent, as well as if you look at the health extension program in Ethiopia, they're employing women. And this, of course, the social benefits as well as the economic benefits of women empowerment cannot be underestimated. So I will try and refine the explanation that Dan had given before to Gary and the team around Financing Alliance for Health, but I also want to emphasize that this is a working definition. As we continue to work in this space, there are different partners that we are engaging, and we will continue to refine and reshape what we aim to do and be adaptable based on the needs of different African countries that we will be serving. So what is the Financing Alliance for Health? The Financing Alliance for Health is a multi-sectoral and multi-partner organization that focuses on working with governments, currently focused in Africa, but hoping to expand in future, and supporting governments to think about building sustainable health systems with an initial focus at the community level. What does that actually mean? What do we mean by helping governments think about? So the first thing is trying to rebalance the conversation between ministries of health and ministries of finance. Having worked in public service for a few years, the challenge we usually had when we were trying to request for, raising the budget ceiling for our ministry was, we went in as a Ministry of Health and we're like, we're saving lives. How can that not be moving you? But for Treasury, it's important. Yes, no one is denying that saving lives is important. But, the dollar to you is a dollar away from education and a dollar away from, defense and a dollar away from other ministries. What Treasury needs to hear is, okay, how is this dollar, given to the Ministry of Health be better leveraged in the larger context? And helping ministries not just talk about the health impact and outcomes, but how that actually contributes to the larger GDP is a conversation that we're supporting different ministries on. We also are able to help them think about, this is what you're trying to do in terms of the program. How well are you designing the program? Are you building sustainability in the design of the community health program? And then we support them in thinking around, how do you cost your plan? How do you develop country-specific return on investments? And then what is now seeming to be the niche space that we're going into, thinking about the financing pathway. What is a financing pathway? It's about understanding this is what we have right now, and this are the different players in the market. This is what they're contributing to what we have right now. In the next 5 years, our program will be redesigned in a particular way, and we would like to have this amount of funds. How do we actually do the resource mapping and be able to identify who should we be partnering with, who should we be having conversations with to ensure that our funding is sustained in the longer term? And if we're contributing 5-10% of the budget, how do we as the public sector look towards increasing that investment as well as crowding in other people to the investment? And that's the financing pathway. What's our value proposition? As I said, being a thought leader, being a facilitator between the different ministries that are working in the space, and we see our role more of a long term. We're not, come in, let's do the plan and leave. But as we continue working with the different governments, we will be having different modes of working and engaging the governments even in the long term. So there'll be times of in-country presence, times for distance in terms of advising different governments, as well as trying to see how we can work through our partner organizations, including Partners in Health, in thinking around how better to serve governments. We have various partnerships and members, and I've listed a bunch of them here. And I just want to call out, I'm very grateful again for the continued involvement of the Partners in Health team through Dan, and I look forward to continuing to work together. This is just an illustration of what the financing pathway would look like. So what we would be saying is, if a government is saying, this is what we're currently contributing and we want to increase that proportion, how do we then crowd in, increase the government contributions, crowd in new sources of financing, as well as trying to see how we can optimize in the current landscape. We work in 3 basic areas. Country engagement. Country engagement is in-country presence, working different ministries. We are demand-driven, and so far we have been grateful to serve Liberia and Sierra Leone at a national level. We've been able to serve Togo at an NGO level, and we're in conversations with 3 or 4 other countries and ministries that are keen to have us come on board and support them. And in country, we contribute to the thoughts around designing of the program as well as the financing of the program. The second pillar is around insights. So as I began, I said, everyone has varying agreements to how much community health systems contribute to the larger health system. And what we're trying to do is we're trying to build a database of knowledge using either case studies, using information that's publicly available or has already been published, but more importantly, also contributing new knowledge to this body of knowledge to show the evidence of the value of the community health workers within the primary healthcare system. And the third pillar we work in is innovative financing. So this is where the bonds that we're constructing come under. This is where the debt for health swaps comes in. This is where the special performance vehicles around performance management occur. We have also developed tools that we use in country, and we help ministries in country use for costing their plans, as well as developing their return on investments. I'm conscious I've been talking for the last few minutes. Are we good so far? Still good? Yeah? Great. Just a bit of detail. I mentioned Sierra Leone, and we've worked there in Sierra Leone with Partners in Health, and we supported the Community Health Worker Hub in developing, just redesigning and thinking through the plan, as well as trying to finance and think about the costing of the plan. In Liberia, we've worked with our partners, Last Mile Health, in similar ways, and especially in the context of the post-Ebola recovery. In Togo, we supported one of the NGOs think about how to, again, design as well as understanding how to cost their community health worker program. In terms of insights, we've done a number of things. We've developed a draft curricula, and so we've realized that in supporting the government, we also have to think about the capability building of the government. So even before we come in country, we need to make sure that the government understands what is a return on investment, what do they need to think about in terms of financing and costing of plans. We also were in Johannesburg in the institutionalizing of community health workers with Dan and the team, and we ran a couple of sessions around financing. So we were able to have conversations with about 22 country delegations from Africa and across different other geographies, and talking with Ministry of officials, again, Ministry of Health and some Ministry of Finance folks, helping them again understand why are we doing this and what's the value towards them. And we're currently working with Dalberg, supported by USA, to develop country-specific case studies, because there's a lot that is out there around what's happened in Ethiopia and Rwanda, but several other countries are running similar programs, and we would like to learn from their experience and build this body of knowledge, as well as doing something that we perceive is very important and needs some work in this space: understanding the funding baseline. What resources are out there? Why are they fragmented, and how can we advocate for more resources in this space? And in the third pillar, we've been working with Total Impact Capital and supported by Credit Suisse to think about these innovative mechanisms that have been and modalities that I've been talking about. We also got support from the Rockefeller Foundation to hold an event in Bellagio in November, where we'll have country delegations come in, those who already have a designed community health worker program, hopefully a costed plan, and then helping them understand how do they actually fund that gap within their plans, and have different financing modalities for them to discuss and identify which would be suitable for their context. A bit more detail on Bellagio. We would like to, first of all, answer some open community health financing questions. So we realize that we are at different stages of our work with different governance and different ministries of health and finance. And some of them have been coming up with new questions. And if we can gather the right people in a room to be able to exchange knowledge and skills and experiences, we're hoping to address a few of these open questions. Again, in some governments, to some extent, the ministries actually work in silos. So you'd be amazed how such forums help to bring specific ministries of a particular country to continue having the conversation around financing. Looking at the products, amending them based on in-country experiences of different ministries, as well as bringing in questions to some of the modalities. So we are developing the modalities based on conversations in country, but we do realize that the contexts in countries are changing. And so as we continue to refine our modalities, we will be able to get the country input from that. And also, frankly, and this is something that I'm very big on, we want to, even as a thought partner and a facilitator, we would like to take our cues from the governments that we serve. So constantly asking them, how can we support you? We don't want to feel like a hammer and now we're just looking for nails, like, okay, we think we have solutions, let's look for the problems that can, it's more of, this is what we have understood from our previous conversations. We are having ongoing conversations. How do we continue supporting you well? And some countries will be like, great, you helped us cost. Guess what? We want to run with this modality and we'll just use you as at a distance thought partner. Other countries are like, look, we need you continuously in country to do a number of things. And we would like to be adaptable and flexible to adapt to those requests by government. Dan did a quick introduction. I love the public and social sector. All my life, it may not look it, but it's significant number of years. I have worked in the public and social and sector. I've served in governments, I've served through NGOs, I've served in consulting, but focused on governments, in the academic and research institutions. I love the public and social sector. It's not straightforward. It's not about necessarily the bottom line and increasing profits by 0.0000001%, but still it makes me happy. And I also understand that there's a role for the private sector and some of the private sector thinking in the public and social sector, and I welcome that. And I'm really looking forward to working with the team, with Dan and Phyllis and the larger team in terms of in serving in different capacities. How is the Financing Alliance governed? Okay, so I say we're a multi-organizational partnership, and we have many partners, and we have focal people in different in these organizations. We are a 501c3, and Capital for Goods is our fiscal sponsor, and we have a high-level council. And so the high-level council are our thought partners in terms of understanding the political landscape. They're the ones who, in 2015 commissioned the report around ensuring that we have the return on investments for community health workers, and they continuously work with us and advise us on, what's the changing landscape and how do we continue to be relevant in this space. We look forward to continued partnership with the Partners in Health team, in the different aspects. In country engagement, you've been valuable. You will continue to be valuable to us, and we look forward to that. And helping us understand the knowledge. You work in a fantastic space across different geographies, and you have the capacity and would like to leverage on that reach. And of course, in innovative financing and helping us think on how those modalities could contribute to the geographies that you work in. Thank you very much for your attention, and I welcome questions or at the right time if it's not immediately after my presentation. Thank you.
We'll take some questions now. Angela will answer most of them, but I'll come up here to support. Any questions?
One of the things that you guys had mentioned during the presentation was that in addition to advising countries on the financing of the CHW models, you also might get involved, depending on whether the country needs it, in providing some technical guidance on those CHW models. Could you guys speak a little bit more to that, how you guys might get involved with it, as well as how you guys negotiate with MOHs around that, especially because it's their final decision on it?
Okay, I'll give some real country examples. For example, in Sierra Leone, we were supporting the Ministry of Health and supporting specifically the Directorate of Primary Care. And we supported Dr. Kande and his team and the Community Health Worker Hub to, first of all, being a member of the committee that comes up with the design. So again, our niche is in the financing, but would like to be a thought, because the design actually affects the financing. We are present in the conversations around the design. There are very many people in that space who work in designing the policies and in the strategies and designing community health worker programs. And our role on that platform is basically giving inputs about, make sure like we're thinking about sustainability, if that is an entrepreneurship model that is built in, or thinking about the reach, thinking about the resources available, and how do we actually adjust the design to ensure that in rural places versus the urban places, we have the right ratio of community health workers to community. And then now we now contribute in taking the lead, supporting the Ministry of Health in taking the lead around the financing. So we are members of meetings and committees. We work very well through in-country presence. So the Partners in Health team who have been there and are there across the entire value chain, we leverage their presence and their knowledge and their relationships in country also. Dan?
That's good. Maybe we'll take another question and I'll add my 2 cents.
Okay, I just want to ask a question about how is this finance, especially speaking of community health workers, how does it work exactly? While countries, we still have a misunderstanding. We don't have a common definition of community health workers and their work. I want to understand how then the financing of the work, how do you really structure that if their work and deliverables are not commonly defined, and even their profile? In some countries, some are volunteers, and other side they are, recognized as workers. So how the financing looks like, and what are the challenges you guys face so far?
I'll stand down. That's a very good question, and it's something that we also in the space have been grappling with in terms of who are community health workers. And the truth is there's significant variability across countries with different ministries, in terms of their training, their exposure, their experience, where they're gotten from, and the kind of services that they deliver. So two things. One, when we currently work in country, we build on the definitions that the ministries of health in those countries actually use, while advocating for good practices. So, if for some reason in a country because of a pandemic, people were getting 3 days of training and being called community health workers, we then think about, okay, in the building out of the system, how do we ensure that they get, a minimum of X amount of training in specific packages and build that out. So we build on that country's ministries of health definition. The second thing is, with the work we're doing with Dalberg, apart from having a funding baseline and understanding the landscape better of what resources are currently available and being used in community health worker space, as well as what is potentially more resources that we can draw towards that space, we're helping we are having conversations around how do we now start streamlining and aligning these definitions for different countries, and how do we categorize community health workers, and we need to understand that there are those community health volunteers, and then there are community health extension workers who have at least a certificate or diploma in a particular area, and then different countries help, deliver different service packages through the community health workers, and some of them are only limited to rural areas and not urban areas. So I don't see an end point where we will reach to one specific definition because of just the different needs across countries, but we would like to be able to categorize the different community health workers and help that guide how we think about designing systems in country. Is that okay? Yes, thanks.
Just to take a moment to add just a little bit of my perspective about how I've seen it work. And like Angela said, this is still a work in progress. But the Financing Alliance was created because of the realization that I think many of us have had in our own work and the way Partners in Health works, is that we want governments to be ambitious about how they think about their health systems, about how they build their health systems. But that ambition then a lot of times will hit against the wall of, well, we can't afford that, right? So then who is helping governments? One, understand what ambition means. Two, cost it out. Three, find money so that you can do it. And who's doing it more than a sort of very passive consultancy where they come in, build a report, drop it on the table and leave and say, well, good luck, And if you don't fix it, then it's your fault. Maybe you're just corrupt. The idea is that there's going to be this group that is based on the accompaniment model, at the elbow support long-term, that has many phases, and that sort of creates this conversation between ministries of health and ministries of finance about, these two levers, ambition and financing. And then once you bring that financing conversation in, then the ambition comes into play. But a lot of questions remain. What is a community health worker? What does ambition look like? I try to represent the Partners in Health experience in that. And it's one of many, but one thing that you'll all be proud to understand is that the question of whether or not you have to pay community health workers is no longer a real debate. I mean, that was our number one debate for decades, and people were saying fantastical things about how, volunteerism and all this other stuff. No one believes that anymore. We're talking about substantive jobs, full-time, doing stuff that contributes to the value chain of a health system. You have to pay them. But then the question becomes, how much? And do they get benefits? And what happens if they get sick? And how do you replace them? And what are the capital costs? And what's their education? Should it be 6 weeks, 8 weeks, a year, 2 years? Should they have a degree? Should they be a civil servant? Those questions, those are budgetary questions primarily, in addition to political questions. So that being involved in that space, I think that's one of the ways in which the Financing Alliance is going to be critical. Any more questions?
So this is wonderful. Congratulations and welcome. We have, for 30 years believed that community health workers are the most important technology in being able to leverage the genius of the communities in which we work and find a pathway to being able to improve health. The challenge from the perspective of our mission is one not settling for anything less than a true preferential option for the poor. If the notion is that we stop at community health workers, then we stop at the least common denominator, even if there's improvement. And the outcome, we can't celebrate vaccinations alone unless people have access to 21st century healthcare in the same way that people do in the rest of the world. The question is, if one focuses on the silo of community health workers without understanding the importance of the other elements that are necessary. And for us, we've seen that as a fundamental, foundational backbone to health centers and district hospitals, tertiary care, and ultimately building a stream of human capital. How do we essentially not over-exaggerate one focus and allow ourselves to settle at the lowest possible level? While there'll be improvement, then we'll celebrate it. It won't be enough. And how do we manage that?
That's a very good question. And as I began to speak, we see community health systems as a component of the larger health system. And we are not looking at it in isolation. We recognize and celebrate the importance of the entire value chain of health systems. And even as we think around designing and financing community health systems, there is a direct link with a facility, with part of the other system. Community health workers are, have to be linked to a facility where they get supervision, continuous training, their supplies. We try and push that link even in our design and even in the financing of the system. So our entry point is through the community, because we see that this is a space that we need to help streamline, but we are actually looking at the entire health system strengthening with this component of in the community kind of service delivery. But we are not looking at that in isolation, not at all. We all work together for the common objective. We just want to be able to bring services closer to the community, but making sure that they are linked to a facility because of ensuring referral is built into that system. So that's how we work. Dan?
And exactly like Angela was saying, when we wrote the report, the 10 to 1 return on investment, that was actually a big debate, because there are people who say, oh no, the community health workers are so good, that's all you need. And that's a real danger. That's siloing, that verticalization. Folks from the World Bank, who created the Global Financing Facility, which is also a partner that we collaborate with in these countries, and I anticipate we'll be collaborating with more, amongst others, said, no, we really have to think about total healthcare system strengthening. And then the question becomes, well, then why do you want a financing alliance for health? Two things to point out. One, it's not financing alliance for community health. That was actually a conscious decision, because the idea was this will be the wedge leverage point, a sort of chol batai, right? But it's really a way to then get the entire health system, starting with this very high value investment of community health. The second thing, and you see this in the report, in the 10 principles, it says you have to build the health system. But the question is, when you are using your wedge issue, how do you not just settle on that? That's the critical question. I would say, to some extent, we have to sort of build that together. The truth is, we're going to need more money for everything. And how do you get that? I mean, if we can barely even afford community health worker programs, right? West Africa right now, the government is trying to build a community health worker program, and it's pittance of money, and they're barely making the amount that they are barely getting the amount that they need to build that. And now we're talking about clinics and hospitals and stuff like that. I mean, I think that speaks to the larger call for action in the international community, that these health systems are really bare bones. They're less than bare bones. I would say also that, it's going to be a process. And we're going to have to learn how to do it together. Any final thoughts about that? Is that convincing, Gary? Just one related point, and then Angela can respond. Also, community health workers are a lot of times, because they're not professionals, at least have not been considered professionals. They're often undermined in these negotiations. So, doctors, nurses, pharmacists, they often have professional societies that represent their interests. Community health workers, if there's a budget cut, they're the ones, and they were getting paid, they're the ones that just get decimated. They get cut immediately. So for me, there was a little bit of justice, saying there's a group now just focusing on helping them and making sure that they're at the table. And these primary healthcare hubs that kind of exist in these different countries, who's helping them cost out their program and represent themselves at the table when they're compared to the surgeons or to the primary healthcare folks? And it's just getting that a better seat at the table. But then also running the risk, of course, of always saying, okay, well, early closure, verticalization, but that's something that I think with our presence in the Financing Alliance, we'll constantly keep that reminder. It can't stop here. A community health worker is not a mini doctor. A community health worker works best with a doctor and a nurse and a health system.
And that's true. And I appreciate your point, Gary. I'm a physician, and I've served in national teaching and referral hospitals in rural areas and hard to reach areas. The truth is, especially in some of these geographies, the skilled labor is very limited and then ends up being very concentrated in particular areas. And I give an example of when I was working in Garbatula, which is a hard to reach in the north of Kenya. There's a semi-arid nomadic community. The people we're serving, they don't stay put, right? They move. But where I'm based, I'm in a facility. And so how do we now bridge that gap in terms of accessibility? I'm willing to treat, and we're all willing to treat at the hospital level, but our community is moving around and, for various other reasons. And how do we bridge that gap? How do we get people that they know and trust? Because community health workers are from the community. The community health workers, they know the people who are pregnant in the community. They know who got a baby, they know where they live, they know what the issues are. We are seeing them as these additional aspects of the entire health system that contributes to the overall health outcomes. We're not going to be able to attribute, saving of lives to this one component. Everyone played a role. What we're saying is, we need to ensure that we have the right supporting cast so that this production works well and does what we are trying to do. And I appreciated the value of these people in the community who are able to say, look, the community actually moved here, and that's where there's water, and that's where we should send our outreach and our mobile services. Because as facility-based people who highly skilled, but probably not even from that community, had no idea, and so I hear what you're saying, and this is not a call to say let's replace other parts of the health system with this one component. No, everyone has their skill and their comparative advantage in the entire system. It's an orchestra. We all play our instruments so that the symphony, that the concert is good. It's not a solo performance, it's a concert. Let's make sure that everyone has the right instruments so that the orchestra works well. That's how I perceive it in my mind.
Final question. We have a few more minutes.
I'm kind of curious to learn about your own business model and your own financial sustainability, because I imagine that this is a really kind of exciting opportunity to leverage technical expertise outside of the Ministry of Health. And I noticed that you've had significant kind of philanthropic investment probably to get it going, which is great. Is your intention in having kind of multilateral organizations as part of your alliance that you become their kind of evaluation arm? There seems to be a big push within kind of institutional funding for scale and innovation. And so are you hoping that that's your financing mechanism? Because otherwise I could imagine you kind of competing for funds with the ministries of health that are trying to design and implement their own community health programs.
That's a very good question, and the conversation that's always ongoing with our team is how do we ensure our own sustainability as FH? And you hit it right on the head. Yes, we have been able to access grants from different philanthropic organizations, but we are looking to continue partnering with existent people in this field, multilateral organizations, and ensuring that our goal is not that we become this X% charge for money going to, no. If a country is supposed to get a certain amount of money, we would like that country to get that amount of money. We're not charge fee for service, charge kind of technical support for ministries of health, and that would not be the preferable option for us. So yes, we are trying to see how we can become more sustainable and partner with the big established multilaterals who say, now you can be our arm to ensure that we are able to get financing as that particular technical expertise.
I would say it's charitable donations right now. It needs a revenue model, but it needed to be done. So like Partners in Health, sometimes you just need to jump into the abyss and hope that it works, because it's the right thing. It's the blank space. You know, these governments, and in Sierra Leone, when I was there, they were like, wait, you guys are gonna stick around and help out and help us figure out how to do this so that we can do our jobs better? That's incredible. And there's technical advisors everywhere, but that really at the elbow accompaniment aspect, which PIH does so naturally in so many countries, that's not available to so many places. So we're doing it, but it is a struggle because it is charitable donations right now. All right. Thank you so much, Angela. Thank you so much for coming all this way. Thank you. And we'll be around all day. So if there's any extra questions, feel free to approach us.